Welcome to the next lecture on valvular heart disease. I am Dr. Rahil here. In the previous video, we discussed aortic stenosis. Now we will learn about aortic regurgitation. Aortic regurgitation is the result of inadequate closure or cooptation of valve leaflets, which results in leakage of blood from aorta into the left ventricle during diastole. It can result from either intrinsic valve disease or dilatation of aortic root. Primary aortic regurgitation is due to disease of the aortic valve leaflets. In developing countries, rheumatic heart disease is the most common primary cause of aortic regurgitation, whereas congenital bicuspid aortic valve account for most of the cases in developed countries. Secondary aortic regurgitation is due to aortic root dilatation. Causes include endocarditis, Marfan syndrome, some connective tissue diseases, and aortitis. Aortic regurgitation may develop acutely in conditions like infectoendocarditis and dissection of the aorta. Chronic aortic regurgitation develop over a period of many years and progressively increase in severity. Aortic enlargement from unclear etiology is the most common cause of chronic aortic regurgitation, followed by bicuspid congenital malformation of aortic valve. Now coming to clinical features. Initial symptoms can include palpitations, dyspnea on exertion, and fatigue. Chronic aortic regurgitation may be asymptomatic for years until overt symptoms of congestive heart failure develop. Acute aortic regurgitation is a medical emergency presenting with sudden onset of pulmonary edema and hypotension or cardiogenic shock. It may also present as myocardial ischemia or aortic root dissection. Coming to signs, there are many eponymous signs associated with aortic regurgitation, but here we will focus on important examination findings. Starting with pulse, it is described as collapsing, water hammer, or Corrigan's pulse. Arterial pulse show rapid rise and a quick collapse, resulting in widened pulse pressure. Apical impulse is displaced laterally in chronic aortic regurgitation due to left ventricular enlargement. On cardiac auscultation, first heart sound is soft. Characteristic murmur of aortic regurgitation is a high-pitched, early diastolic decrescendo murmur heard best at third left intercostal space, also called Ubbs point, on end expiration with patient sitting up and leaning forward. The severity of aortic regurgitation correlates well with the duration of murmur instead of the intensity. Murmur of aortic regurgitation sounds like this. Investigation. Like all other valvular heart diseases, echocardiography is the best non-invasive test to diagnose and grade the severity of aortic regurgitation. Now coming to management, acute aortic regurgitation is a surgical emergency. As patients are in cardiogenic shock, they need hemodynamic support with inotropic agents and vasodilator therapy for stabilization before surgery. Aortic valve replacement or repair should be performed as soon as possible. In chronic aortic regurgitation, left ventricular ejection fraction is one of the important factors for consideration of valve replacement or surgical intervention. Patients with an ejection fraction of 50% or less have decompensated disease and require surgery. Asymptomatic patients with severe aortic regurgitation should be referred for intervention if the left ventricular ejection fraction is reduced to 55% or less. This concludes the discussion of aortic regurgitation. Thank you for watching. I will see you in the next video on pulmonary and tricuspid valve problems.